Hello, welcome to our lecture on safety in wound care. This is Professor Kirby. I'm going to be walking you through this lecture, and hopefully we learn a little bit about wound care today. Okay, so let's start with our objectives. We have many. I'm going to mostly let you read through those, but we are going to learn about asepsis and surgical asepsis and when to use those different asepsis. And we're going to look at the skin and the phases of wound healing. What affects wound healing? We're going to look at different types of wounds and staging them. And we're going to talk about some drains and how they help with wound healing. We're going to look at some of the wound care products that are out there and cleaning, debridement. We're going to look at heat and cold therapy and when to use those, and a couple of nursing implications, especially when we look at our geriatric population. Then we're going to look at ways to promote tissue healing and how we can prevent complications from happening when it comes to wounds. Also documentation and patient care, and the basic principles of surgical asepsis. We're going to walk through that. Okay, so now that we've talked through our objectives and what you need to know, next let's talk about medical and surgical asepsis. So there are two types of asepsis in healthcare. There is medical asepsis and surgical asepsis. So let's look at medical asepsis first. It's also called clean technique. So this helps to reduce the number of microorganisms, disease-causing microorganisms, after they leave the body. It's used to care for clients with infectious diseases, to prevent reinfection, to avoid spreading of infection from one person to another, and also to keep it from spreading throughout the facilities. So the core measures of, or the core practices, I guess, of medical asepsis or clean technique is hand washing, number one. It's the best and simplest way to prevent the spread of infection is washing our hands, as we've learned, sorry about that, with our coronavirus. Making sure that our environment is clean, following standard precautions, making sure our equipment is clean, that we're using proper PPE, our gloves, gowns, masks, face shields, when appropriate, hair and shoe covers. I think we are now very comfortable with PPE because of the pandemic. Disinfecting articles and surfaces, using chemicals to do that, and again, proper hand hygiene is the key. Isolation precautions are also an example of medical asepsis, and that the client and the client's environment and the healthcare providers are protected from contamination or reinfection through medical asepsis. And also how we handle linens, right? We can't, when we're changing a patient's bed, you need to roll the linen into itself, and you can't hold the linen against your body because now you've contaminated your scrubs, and then you can potentially carry that into other patients' rooms, so you have to make sure that you're holding the linen away from your body. Okay, so next we're going to talk about surgical asepsis. Surgical asepsis is also called sterile technique, and in this surgical asepsis, we want the absence of microorganisms in order to prevent infection. So we're going to eliminate those microbes before they can enter a surgical wound or contaminate a sterile field. So think about the OR, right? It's a very sterile environment. So this includes the sterilization of all instruments. They use drapes and other objects that could potentially have contact with the sterile wound or field. All of the healthcare providers and the staff who have contact with the sterile field have to follow certain procedures, the first of which is a surgical hand scrub. So before they even go into the OR rooms, they have to wash their hands, and this goes from the fingertips all the way to the elbows. They use special brushes to get into all of the nooks and crannies of the hands and underneath the fingernails to make sure that the hands are as clean as they possibly can before they don sterile gloves and surgical gowns. So surgical asepsis is always practiced in operating rooms, also in special procedure areas like outpatient surgery, diagnostic areas. A lot of tests need to be sterile, burn units, labor and delivery areas. Also used in invasive procedures that are done at the bedside, like inserting chest tubes, central lines, catheters. So one of the sterile techniques you will learn later this semester is inserting Foley catheters. So we'll talk about why that is important in a little bit, about why that needs to be done sterilely. So that's medical and surgical asepsis. So just a couple more examples. So with sterile technique, starting an IV, administering IM sub-Q injections. We want to make sure we don't contaminate those needles before they enter the body, right? Inserting a Foley catheter, bladder irrigation, dressing changes on an incisional wound, administering eye and ear drops. Whereas your aseptic or clean technique is administering non-parenteral medications, oral, rectal, sublingual, and intranasal medications. So it used to be that we would perform sterile wound care. You'll hardly see that in the hospital setting anymore because most wounds are considered dirty or contaminated. So a lot of times you'll just see clean technique when it comes to wound care. So just when you're out in clinical, be on the lookout for that. Of course, we want to be as clean as we possibly can because we don't want to contaminate our wounds. But just a note on that. Okay, so let's talk about the basic principles of surgical asepsis. So these are kind of the rules when it comes to making sure that we are staying sterile. So most of us instructors are very strict when it comes to sterile technique because we want you to really develop good habits, and that starts in the lab and that starts in clinical because you're going to carry these habits and skills over into your professional practice as a nurse. So just be open to getting some feedback and some correction. And when you're in lab, try to have that focus of sterile technique and correct each other and be open to correction, okay? Because when we do the sterile wound the dressing lab, you'll be surprised at how many times you contaminate your sterile field and you won't even notice it. So it's important that we point that out to you. Okay, so the first rule is that all objects in a sterile field must be sterile. So we set up a sterile field with a drape or inside of a sterile package. Almost anything could be your sterile field, but they do have sterile drapes, or like when you open a package that is a sterile package, inside of that package is considered sterile. So whatever your field is, whatever you're working on, whatever your procedure that you're doing, make sure that you know where and what your sterile field is, and everything in that field must be sterile and kept sterile as you're moving around, otherwise you're going to contaminate it. So never assume that an item is sterile. So when you're taking your supplies out of the supply room, make sure you're inspecting them to make sure that the packages are clean and dry, they haven't been opened, and somebody put something back. Want to make sure that those dressings are intact. So when in doubt, throw it out. So in the picture, you'll notice how they're opening the sterile package. We'll go over this in lab, but you want to pull away from the middle and keeping the integrity of the sterile field inside. So whatever that nurse is opening inside that package is sterile. So you want to make sure that you're opening it sterilely, which we will do and practice in lab. Okay, so the next principle is that sterile objects become unsterile or dirty when they're touched by unsterile objects. So once you've contaminated or touched your sterile field, it's now dirty. So you have to manage that appropriately, whether that means that you don new gloves, that you throw out the item that you contaminated. In some instances, you may need to completely start at the beginning of the procedure because it's no longer safe for the patient because you've contaminated things. So you can use sterile gloves as you're moving about your sterile field. We'll go over this, of course, in lab. Using forceps and things so that you're not actually touching the sterile objects and that the device is actually touching them. The next principle is that items out of sight or below your waist or the table level are considered unsterile. So when you are setting up your sterile field on a bedside table, for example, you have to position it in such a way that when you're moving about the patient and turning from your sterile field to the patient, that you are not turning your back on your sterile field and that you're also keeping it at waist level. Again, we will do this in lab, so it will be a lot more clear, but you need to have a kind of a clear picture before we go into lab of what the basic rules are. So in the picture on the right of the screen, where she's setting up her sterile field, she set it up in such a way that she's not going to turn her back on the patient, or the sterile field. And then once you've donned sterile gloves, it's really important that you keep your hands above your waist level. So as soon as you drop those hands below your waist, you're now not considered sterile anymore. So something really important to consider too is as you are dropping dirty things into a trash can, for example, a lot of times students will reach below their waist in order to drop it into the trash can. So we'll show you in lab different ways to drop items, but think T-Rex arms, that you need to keep them up out of the way. And you've seen ER and some of those medical shows where they're scrubbing in and they keep their hands up, at chest level. That's what I need you to think about, is to keep those hands in front of you and above your waist. Also your table too, you don't want to position that too low as well. So everything needs to be waist height or higher. Okay. The number 4 principle that we're going to talk about is that objects can become unsterile by being prolonged and being exposed to air. So if you think about how a lot of microorganisms travel, they are airborne, and having a sterile field out in the air, by very nature, there's microbes that are floating around, especially in the hospital. So it's important that we control that air as much as we can. So a lot of sterile procedures will tell the patients not to talk, or we'll have them wear a mask or decrease talking, because their talking can actually introduce microbes into the sterile field. So as you're opening your packages, you want to open them away from you. So you see in the picture, she's opening some sort of sterile package, right? She's opening the first tab away from her. That's going to make sure that she doesn't contaminate and cross over her sterile field. Her arm, as you notice, is to the side of the package and not over the package, because as soon as her arm crosses over that sterile field as she's opening it, then it's no longer sterile. Again, we're going to go over this in lab. Hopefully it'll make a little bit more sense then. So you never want to reach over your sterile field. You always want to go around it. So you want to decrease the movement of sterile objects. So as you're setting them up, you want to position them in such a way that it's going to be easy for you to perform whatever procedure you're doing. You want to decrease the traffic in the room, close doors. Sometimes we'll put notes on the door. If you are lucky enough to see a PICC line insertion, the PICC line nurses will put a note on the patient's door. They'll close the door and say, sterile procedure in process, do not enter, or something along those lines. And they really want to limit the amount of people that are in the room just because of that air movement. So next is we're going to talk about fluid, and that fluid flows in the direction of gravity, right? So as you are washing your hands, you notice that she's washing from clean to dirty there. So her hands being the most important, she's washing down towards the less important areas of her arms. When it comes to forceps, you want to keep the most sterile part, the most important part, like the tips up, so they're not accidentally touching something that might become unsterile. Moisture, so moisture passes through sterile objects, and that can draw microorganisms from unsterile surfaces above or below the sterile field. So you want to make sure, especially if you're working with fluids, which we will with our wound care and our trach care and our Foleys later, you want to make sure they're not splashing that liquid around, that you put some waterproof barriers under your sterile field. So these a lot of times have a plastic lining so that it catches any fluid. When we do our Foleys, you'll see that as well. Okay, this is an important one. So the edges of the sterile field are considered to be unsterile. So the 1-inch margin at the edge of an open drape is considered unsterile, or a zone of contamination. So as she opened that drape on that table, the last inch all the way around, 1-inch border, is considered unsterile, which is also nice because that means we can touch and move that area without worry about contaminating, because it's already contaminated. So as you're placing objects on that sterile field, like that nurse is doing in the picture with her sterile drape there, she needs to make sure that she's placing the objects in the middle of the sterile field, and they cannot touch that 1-inch border. So 1 inch is the magic number in this case. Next, skin cannot be sterilized and is unsterile. So that comes to our own skin. That also is true for wounds and things like that. So wearing gloves is important. When we are taking off old dressings, you want to wear clean gloves. And then we get rid of that old dressing. We take the gloves off properly. We doff them and put them in the trash. We clean our hands, and then we put on sterile gloves in order to apply new dressings, which we're going to do in lab. So you only use sterile applicators or forceps to hold sterile objects if you're not going to touch them with sterile gloves. If you're using antiseptics, they only make the skin clean, not sterile. So you're never going to be able to make an old wound sterile. So those are some examples of different antiseptics that could be used. Okay, last one. So you need to make sure that you are conscientious, alert, and honest when you are dealing with sterile technique and surgical asepsis. So honesty, that means that you verbalize when you've contaminated a sterile field. Even the best surgeons and scrub nurses verbalize when they've contaminated the sterile field, and they'll say, oh, I contaminated, the left side of this drape. And everybody knows that it's contaminated, and they will either try to fix it if they can, or they'll avoid that area if they can. So it's better to start over or to grab new supplies than to give the patient an infection, which we're going to talk about. So like I talked about a few minutes ago, evaluate your own performance, help other nurses. Sterile technique is really an art. You have to learn the rules and practice a lot. So practice, practice, practice. Don't be afraid to receive feedback and to give feedback as we're practicing in lab. Okay, so why are we so concerned about keeping things clean and sterile? Well, healthcare acquired infections is why. So these are infections that occur while a patient is in the hospital. So there is a number of them. They're regulated by a national and state healthcare organizations. So they are infections that a patient can get while receiving medical treatment in a healthcare facility. And all of these are reportable, which means that if any of these happen in the hospital, nurses and the facility is mandated to report them to their governing body, whether that be CMS or JCAHO or whoever keeps the data for that area. So HAI is abbreviation for healthcare acquired infection. So some examples of these are central line associated bloodstream infections. We abbreviate that CLABSI. Or catheter associated urinary tract infections are CAUTI. Our select surgical site infections, which is SSI. C. diff that is acquired in the hospital. We can get MRSA from the hospital. You can get pneumonia. And then the one that is concerning to wounds is hospital-acquired pressure ulcers or pressure injuries. So wounds that occur while a patient is in the hospital are called hospital-acquired pressure ulcers or injuries. They're often abbreviated as HAPU or HAPI. It's not very happy though. So according to the Joint Commission, our HAPU-HAPI injuries result in a significant harm and can cost as much as $70,000 to treat. They increase length of hospital stay, and they even can cause premature mortality. More than 2.5 million patients suffer from just the hospital-acquired pressure ulcers or injuries. Just acute care facilities, folks. Not even our SNFs and long-term care. Just in acute care. Oops, sorry about that. And that more than 60,000 people die from their complications. This is a huge deal and costs the healthcare system millions, maybe even billions of dollars a year. So this is why we have to work so hard to prevent these injuries from happening. Some patients come to the hospital with existing wounds, so it's very important that nurses chart on them as pre-existing, or they'll count as hospital-acquired, and we will take on that, even if it's an old, nasty, obviously pre-existing wound. If we don't chart it within a certain amount of time, it actually becomes hospital-acquired. And what happens if there's hospital-acquired infections? Well, the hospital does not get reimbursed by Medicare and many private insurance. This means that the hospital has to eat those costs associated with that injury. And they are very costly. Okay, so how do we help prevent skin breakdown and impaired skin integrity? So this is the Braden Risk Assessment Scale, or the Braden Scale. It's one of the most common tools that hospitals use. And there's 6 subcategories that measure the elements of risk that contribute or put a patient at risk for pressure and tolerance for pressure. And basically it helps nurses to assess the patient's risk for pressure ulcers for me. There are 6 categories, including sensory perception, so how alert they are with it they are, moisture, how wet the patient is, activity, mobility, friction, and shear. So it's a clinical judgment tool in which the risk is assessed and should lead the nurse to taking appropriate action to decrease the risk of skin breakdown. So the lower the score, the higher the risk of skin breakdown. In other words, a low score is a poor score when it comes to this scale. So typically hospitals have protocols in place for low scoring patients that automatically prompts the nurse to take preventive measures like changing out the patient's bed to a different type of bed that's more conducive to preventing wounds. Also putting on a different surface like a waffle mattress, air mattress sort of surface, using pillows to pad bony areas, frequent turning, even putting on foam dressings on some of those bony prominences like the coccyx or the elbows or the heels. Oftentimes those are called Mepilex or other sort of protective barriers that just help prevent skin breakdown in our very at-risk patients. Okay, so let's get into some of the specifics of wounds. So if you remember back to anatomy and physiology when you learned about skin, there's the different layers of skin, and we have the epidermis, dermis, and the subcutaneous layer. So this is also how we are going to qualify and quantify our wounds. So they're classified as superficial, which is the loss of the epidermis, partial thickness, which involves the epidermis and the dermis, and full thickness, which involves the epidermis, dermis, and subcutaneous fat. So depending on how deep the wounds are, that's how we're going to quantify them. Okay, so let's talk about some terminology. Incised. That is the intentional or even accidental cut that happens for example, in surgery when a surgeon uses a scalpel. Or it could even happen in a knife fight or things like that. So in this type of wound, though, there is clean, even edges. Contused, that's a blunt blow, and oftentimes there's ecchymosis, bleeding, hematoma, which is bruising. So you can see that in the picture on the left there. A puncture, this is a stab by a blunt instrument. IM injection is to a certain extent a blunt. Also, being punctured by any sort of object. Also, inserting a drain is technically a puncture. Laceration, that's torn tissue with irregular edges. That's the middle picture there, would be a laceration. Penetration, that's a probing through the skin into the tissues. That's a gunshot wound, or GSW. That's the picture on the right there, that gentleman suffering from gunshot wounds. Okay, so wounds can have different colors, and depending on those colors is how the wound is doing. So the first color would be red. So this is an example of a red wound. Red and ready to heal. So red is good. Red means that you have good blood flow and there's good granulation tissue. Granulation is like the brand new tissue cells of the skin as it's starting to heal. Revascularization apparent. So this looks like a really nice, clean, healthy wound, right? It's nice and red and beefy. So in this case, we want to make sure that we're keeping the wound site clean and moist and protected. We want to help continue that wound healing that's happening. Okay, this is a yellow wound. Yellow is yucky, right? So that means there's some sort of infection that's going on, or some sort of film. So pus, debris, fibrin, got yellow exudate present. So this most likely is going to require this to be cleaned, some minor debridement, which is the removal of that yellow slough. We want to, because the skin's not going to heal very well with that on there. So we want to promote formation of that good granulating tissue. So a lot of times we can apply some sort of antimicrobial to the wound that's going to help kind of get rid of that yellow. So in this sort of wound, we want to make sure that we apply some sort of preparation that's going to help lift off and separate that yellow pus, fibrin, and necrotic tissue from the wound surface, because it's really not going to heal very well with that on there. Okay, black. I'm sure you can probably deduce that black wounds are not good, that they're necrotic, and anything that's necrotic is, dying or dead. So that is black eschar is what that would technically be called. And it could include, some pus or fibrin that can inhibit formation of granulating tissue. So in this case, there's no healing to this. This is dead. You're not going to bring that back. You're not going to revascularize that. It needs to be removed surgically or mechanically. So they need to get in and chop that out. So they will do I&D, incision and drainage, where they're going to debride that and get rid of all that blackness and scrape down to where they can get to healthy tissue. They can also do that chemically as well, where they put different medications on there to debride it, but a wound like that in the picture is going to need some surgical debridement. Okay, so you always want to treat wounds as the most severe condition present. So in this wound you have some good and bad things going on, right? So we have some red and yellow. So our treatment is we need to take care of that yellow. We need to treat the worst issue of the wound. So in this case, we need to make sure that we are using something that's going to lift off that yellow tissue. And some sort of topical antimicrobial is probably what's going to need to be used. And a lot of times, you don't need to know exactly what that medication is. You're the eyes and ears for the doctor, so you're going to report that, and then they will prescribe something, or you'll collaborate with your wound care nurses in order to get a treatment plan for that, and then you'll do the dressing changes as ordered. Okay, again, treating the most severe condition present. So in this picture, obviously, we got some yellow and black present. So the worst issue here is the black eschar. So we need to debride that either mechanically, they're going to scrape that off, or in surgery, or they're going to use some chemicals in order to dissolve and get rid of that necrotic tissue. Because again, there's not going to be any healing that takes place until that necrotic tissue is out of the way. Okay, this wound, we have all three things going on. We have all three stages, red, yellow, and black. So you can have wounds that are combination wounds. So what's the worst issue in this wound is the black, right? The eschar. So again, we need to take care of that first before we address the other issues. So again, that's going to be some sort of debridement to get that necrotic tissue out of there. Okay, so let's talk more specifically about staging of pressure ulcers. So the stages are used to quantify the amount of damage that is present. So our stage 1 wounds are the wounds that are closed and intact. So you'll see those reddened areas. On the left we have a heel, and on the right we have a coccyx. So they are both very closed but red. So what you're going to need to do if you see those wounds is you need to touch them and feel them. So they're red. When you touch it, it shouldn't blanch. So blanching means like if you touch your skin and hold it for a second and then lift your finger, how it turns white for a second and then the blood rushes back and it turns back to your skin color. That's blanching. So if you were to test that, those little areas, you were to touch them, they would not blanch, which means they would not turn white, they would stay red, and they'd also be warmth. So that's the first indication that you have a stage 1 pressure ulcer. So this is why we do turning and all of these things. You'll see these areas start to get a little red, and when you notice that, you got to check for that blanching. If it's still blanching, that means it's not a stage 1 yet, but that means you need to intervene now before it gets worse. Okay, stage 2. So as you can see from the pictures, the wound is starting to get worse. So the skin is no longer intact. We have some partial thickness skin loss of the epidermis and the dermis. It's still superficial. A lot of times they look like little abrasions or even like a blister that's popped, little concave hole. There's no bruising that's taking place. So it can be like a little shallow open ulcer. It can be pink or red. There can even be some yellow slough in there. But the key here is that it is very shallow, very superficial. Stage 3, we're really getting into some serious wounds. So stage 3 is full thickness skin loss into the subcutaneous tissues. And there's a lot of damage, and it can be necrotic, meaning that black. So the damage extends down to the subcutaneous tissue, but it does not get to the tendon, muscle, or bone. So that's how you're going to tell the difference between stage 3 and stage 4. There could be tunneling. So if you look at that top wound on the right, there is some tunneling, which means that if you were to take a Q-tip and kind of poke around, not only would the wound go down, but it would also travel to the side. That's tunneling. Okay, stage 4. These wounds are not good. So they're full thickness, which means the wound goes all the way down to the muscle, tendon, or bone. There's often tunneling, as you can see in several of these pictures. And it can actually have sinuses that develop. These are different areas and tracts. Slough and eschar is present. We're getting into some, we're going to need some major wound care here. Okay, unstageable. So that means that we can't give it a stage based on what we're seeing. So on that picture on the left, so it involves the subcutaneous tissue that's kind of getting in the way. We're still talking full thickness. Most times unstageables are stage 3 or 4, but it's covered with slough or eschar that's preventing us from really seeing. So the damage is actually deeper than what the eye can see, but there's something in the way that's blocking us from seeing it, whether that be some slough or eschar or subcutaneous tissue. A DTI, that's the picture on the right, or a deep tissue injury. The area is intact, so it's not open, but you see that purple maroon, it almost looks like a really hard bruise. It's like a discolored or blood-filled blister. It's painful, warm to the touch. So that is basically an injury that's occurred that has turned that whole area into eschar, but we can't really tell what's going on there. So that's a DTI. So wound drainage, so that is basically what's coming out of the wounds and how you're going to describe that. So serous drainage is clear yellow, like plasma in color, so it's like a yellow tinge, like when you pop a blister, that sort of fluid coming out, that would be serous. Purulent is basically like infected pus. So it can be thick, yellow, green, grayish, and those need to be cultured. So they'll take a special Q-tip and put it into a special little vacuum container and send it off to the lab to know what the causative organism or what's growing in there, so they know which medication or antibacterial to put on there as part of the wound treatment. Sanguinous is blood. So bright red, new fresh blood from a wound drain, for example, would be sanguinous. So like a Jackson Pratt drain from fresh surgery would be normal for that to have sanguinous blood. We'll talk about drains in a little bit. They contain high number of red blood cells. Dark red means it's older blood versus bright red is new fresh. Serosanguinous, this is clear watery red plasma with some RBCs. So if you think of like a fresh surgery and the first day or two is going to be sanguinous, as the blood starts to slow down, you're going to see more of a serosanguinous. So it's more reddish yellow or like a pink tinge. That would be serosanguinous. So as our wounds are starting to heal, we're going to classify them a little bit differently too. So primary intention, this means that the wound edges are approximated. Approximated means that they're close together, or that there's no tissue loss there. So surgical wounds a lot of times are going to heal by primary intention because they're just able to push that skin right back together. It can be sutured closed at the time of initial surgical incision, or like a really clean laceration. If you've ever cut yourself or gotten a paper cut and you're able to push it back together and bandage it up, or you've used a Steri-Strip or butterfly bandage on wounds, that would be primary intention. So the wound is sealed closed but the underlying tissues still need time in order to keep healing. We have to protect those wounds from stress. Secondary intention, these are for deeper tissue injuries. These are injuries in which the wound edges are not able to be approximated based on the injury or how they were injured. So there's a loss of tissue integrity. So that means that there's a gap, and that requires a gradual filling into the dead space with connective tissue. That means that the body has to fill up that hole or gap. If there's drainage, it might take longer to heal. So chronic pressure ulcers, venous stasis ulcers, burns are all examples of healing by secondary intention. So these wounds need protection and moisture to facilitate healing. Primary intention. So this refers to delayed primary closure. So they're often left open, like after debridement or in inflammation subsides, or we need to watch an area, for example. We make sure there's no infection. So examples might be dog bites, lacerations from foreign bodies, contaminated traumatic wounds, those sort of things. They are going to heal by tertiary intention. Okay, so now let's talk about wound healing mechanisms. So for our partial thickness wounds, these are superficial. There's minimal tissue integrity loss. They basically heal by the body just putting down more of those epithelial cells and using fibrin clots and growth factors, and it's just going to keep laying down new skin layers, and it resurfaces with keratin, and the healing usually takes 5 to 7 days. So hydrated skin always heals better, well oxygenated skin, and if there's no microorganisms, you're going to have a faster healing. Full thickness wounds, remember there's a loss of tissue integrity, and that damage goes down into lower levels of the dermis and subcutaneous tissue. So these wounds can't heal by reepithelialization. This healing occurs by filling in with granulization, so cell regeneration. So it takes a lot longer for the body to lay down those granulated cells and eventually fill in that full thickness injuries. Okay, so assessment and evaluation. So when it comes to care plans, your NANDA for any sort of wounds is going to be impaired tissue integrity, right? So you always want to assess the wound first and monitor for signs and symptoms of infection. A lot of times in the hospital, they'll take pictures, which is great. Make sure you eyeball the wound yourself, because pictures, can be deceiving. So you want to record the location and the size. And when we're talking about size, you want length, width, and depth. We'll talk about how we're going to measure that in lab. You want to talk and describe the drainage type and amount, and what the wound itself looks like in the surrounding areas. So is there any slough? Do you see granulating tissue? What sort of drainage do you see? How does the surrounding areas look? Does it look macerated, like it's too wet, dry, cracked, things like that? So you want to make sure that we're educating. You never, ever want to massage reddened skin areas or use like those little donut-shaped pillows for pressure relief, because those can actually make matters worse. So we want to use our interdisciplinary team members, like our dietitians, our wound care nurses, and our physician colleagues to help. Also our PTs, physical therapists. Okay, so factors affecting wound healing. So the young people always heal more quickly. Remember when you were a kid and you'd get a cut and it would just heal in a few days? Well, not so with the elderly. They have a lot more health issues and comorbidities and chronic diseases that just slow wound healing. So diabetes is a major one that slows wound healing. Also peripheral vascular disease, because you have less blood flow to those areas. Decreased mobility puts more pressure on the skin, puts you more risk for injuries. Nutrition. So wound healing requires additional calories. And if you're malnourished, you are going to heal very slow. If you're obese, there's less tissue perfusion to fat, unfortunately. And you're at greater risk for infection. When I had my first child, which I'll get into a little bit more detail about what happened, but I had my C-section got infected and a hyst, which I'll talk about in a minute, but basically I had this huge gaping wound in my abdomen that took almost 9 months to heal, and I was trying to breastfeed at the same time, and finally my OB was like, you can't, like your body cannot heal and breastfeed at the same time. Like I was actually not helping my wound heal because I was, so much of my body's healing energy was trying to go into breastfeeding. So once I decided to switch to formula, that my wound started to heal a little bit better, something that I had never even thought about, even being a nurse at the time. So there's a lot of factors that affect wound healing. So if you exercise, it actually increases circulation. Smoking is not great for wound healing. It actually decreases our functional hemoglobin and increases clot formation. Stress is not great on wound healing. It decreases tissue perfusion and also causes vasoconstriction. Also, caffeine, darn. Medications like anti-inflammatory agents, steroids delay wound healing for sure. Anybody who's on steroids, their wounds take longer to heal. Antibiotics, if you're prolonged antibiotics, you're at increased risk for overgrowth infections or superinfections. And of course, our immunocompromised patients are at higher risk as well. Nutrition. So these people with wounds need to decrease their water intake, increase their calorie intake, protein, and supplements and vitamins. So all of these vitamins, A, C, E, iron, and zinc, are all often prescribed for somebody who has chronic wounds to help heal those and give the body the best chance at healing. So for care planning and you have somebody who has impaired skin integrity, you may want to include that as an intervention to recommend or collaborate with the dietitian to see if we can make some dietary changes, and you may need to recommend to our physician colleagues to add some vitamins in order to help with wound healing. So with our geriatric or elderly population, we do have some very specific considerations. So our vascular system changes as we get older, and you get atherosclerosis and atrophy of the skin and capillaries, and then we have less collagen and less fat. So the skin is less flexible. There's less cushion there. Your immune system isn't as great, so you're at increased risk for infection. You don't have as many white blood cells and antibodies to fight those off. You tend to have more nutritional deficiencies as you get older, like anemias, and our O2 levels just aren't as high. Our inflammatory response is lower. Less protein and collagen formation, and oftentimes the wounds do scar simply because the skin is less elastic than when you're younger. So hemorrhage, let's talk about, complications. So hemorrhage is a bleed basically, persistent bleeding, or the clots just start forming or being dislodged. Externally, you'll see visible bloody drainage. Internally, swelling, distension of the wound area. If it's really severe, a bleeding wound, you can get hypovolemic shock. You'll see decreased blood pressure, increased heart rate, and respiratory rate as the body's trying to compensate. Diaphoretic, sweaty, and they get kind of clammy and irritable. Another complication is hematoma. Hematoma is like a fancy word for like a bad bruise. Blood accumulates under the skin at the wound site. They can be very large. I've seen a lot of really large, painful hematomas in a lot of the traumas that I saw on my trauma floor, motorcycle accidents and things like that. So there's no great tissue perfusion to hematoma areas. Thrombosis, which is clot formation, and those clots can actually embolize or travel to other parts of the body and wreak havoc. Another complication, of course, is infection. So with surgeries, we're always at risk for infection about 2 to 11 days post-op. Highest risk, so unintentional contaminated wounds, so GI wounds. The GI tract is just dirty, and hospital-acquired infections. Okay, so back to my C-section story. So my C-section got infected, and I got readmitted to the hospital a week after having my first, and they were hitting it with the antibiotics and talking about putting a drain in and all that, and I got up to go to the bathroom, and I felt a pop, and all of a sudden there was fluid all over the ground, and I looked down, and my wound dehisced, which is basically separated out. So the stitches and the dermabalm, surgical glue, opened up with the infection trying to seep out. And so dehiscence is the partial or complete separation of outer wound layers. Once it's dehisced, there's really not much they can do. The wound edges are just not approximated anymore, and oftentimes they can't suture that back together. So evisceration, so that is a wound that has all of the layers of the skin has totally separated, and that actually the internal organs can actually poke out, which is not good. So I didn't have that. I was close. They were really worried that I was going to have evisceration, so I had to be very careful for a while as my wound healed. A lot of times abdominal surgeries are at risk for this, so C-sections and exploratory laps and things like that are at risk for dehiscence and evisceration. So risk factors: obesity, malnutrition, diabetes, immune deficiency, steroid use, suture failure, forceful coughing. So a lot of times with our abdominal surgeries, we teach them to splint with a pillow or to hold their stomach while they're coughing so it doesn't put too much pressure on those sutures and pop them. Vomiting or straining. You don't want your post-abdominal surgeries to be thrown up or to strain while they're having bowel movements. So these are medical emergencies, especially the evisceration, because the body can actually go into shock a little bit. So fever, tachycardia, pain, and you might see a lot of fluid seeping out of there. Okay, so wound healing complications. So stay with the patient especially if you have that evisceration. You want to cover the site with a sterile dressing that's soaked in normal saline. So you want to keep your internal organs moist. Contact the physician, and you want to prevent it by teaching them to splint, like I was talking about with the pillow when they're turn, cough, deep breathings, TCBD. Other complications are fistulas, which are abnormal openings between two or more organs. So this can happen a lot of times in GI wounds. So if you get that tunneling, it actually tunnels so far that it creates a new tract or a fistula. So this can happen due to improper suturing. There's not great blood supply to the surgical site. Maybe there's some tension on the suture line, or there's something in the way, like obstruction, hematoma, malnutrition. So they have to either surgically repair this, they'll do wound packing, or they may insert a drain in order to drain that excess fluid that may be creating that fissure. Okay, drains. So surgical drains are used for a variety of reasons. A lot of times they use them in post-surgery because the surgical area creates a lot of fluid or blood, and you don't want that blood either going into a free cavity or building up and creating stress on the suture sites. So it decompresses or drains the fluid and air, helps get rid of that blood, pus, depending on the type of drain, and it helps to relieve pressure on the sutures. So because if you have a lot of swelling and blood formation, it's going to pop those sutures. So there's different types of drains. So when you're in clinical, please peel back those covers and look, especially if you have a post-op patient. Look at those drains. Ask the nurses about them. What kind of drain is this? Ask if you can drain it. Okay. So the one on the top right that the lady with the blue hands is holding, that's called a hemovac. So that's a drum-like drain. So she's squeezing that. If she lets it go, it'll go into like what looks like a drum. So you squeeze that, and then it passively creates some pressure to suck out the blood. A lot of times they use those for hip surgeries. A Penrose drain, that's the one on the right. That's that little noodle-looking guy that's poking out of the skin. So they put that in, and then it creates a tract in which it can drain, and you put a dressing over that, and then the fluid or blood drains right into that dressing, and you change that. And then the one on the bottom, the Jackson Pratt, or the bulb, that has the tube that goes to the little circular drain. So they use those in a variety of surgeries, abdominal surgeries, mastectomies, hip surgeries, all kinds of things. Very easy to use. So you compress it, and then there's a little plug on the top that you put, that you cover, and then it passively pulls the blood out into that Jackson Pratt drain. So try to get your hands on the drains in clinical. We will have some drains during our wound care day too, so you can play with them a little bit. Just try to ask a bunch of questions and get comfortable with them. Okay. Wound care. So for open wounds with sutures or staples, oftentimes they'll be left open to air. A lot of times, if a surgeon has done the surgery, they're very particular, and they'll give you specific orders, so you don't necessarily need to know exactly what to do in every situation. So you want to make sure that you are keeping an eye on your wounds, that you want to be able to identify early on if there's any poor wound healing or infection. So air drying promotes healing a lot of times in wetter wounds. So that's your open wound care. So closed wound care, so that means it's going to be covered. So dressings are covered. Oftentimes these are for wet wounds. So dressings covered with absorbent pads. So if it's a surgical patient, usually the surgeon always does the first dressing change. So they want to look at the wound. And then nursing will do the dressing changes after that. So if you have a post-op patient that has a still surgical dressing on there, usually it's an OR dressing. It's usually silver or white. You'll see when you get to clinical what the surgical dressings look like. They are different than the floor dressings. But if it starts to seep or leak around it, you don't take the old dressing off. You never take the first dressing off. You reinforce it. So you put like abdominal pads or gauze over it and you just keep stacking it up. Or you put like a Chucks or something underneath it and you let the surgeon know and they'll come take a look at it. So this helps to keep the wound edges approximated, remember, close together, and protects from contamination. Cleaning wounds. So oftentimes we clean the wounds as we are doing the dressing changes, and that helps to remove debris and microorganisms that might be stacking up in there. Usually we use normal saline unless the order specifically says to use something else like hydrogen peroxide, or that's not used very often, Dakins. There's all kinds of things that are used, but there'll be a specific order what to clean with. So you always want to clean from clean to dirty. So usually like the inward to the outer of the wound. This prevents new microorganisms into the wound. The center of the wound is typically considered to be cleaner than the surrounding skin. If you have a wound that is like just a straight incision, you always clean from top to bottom. So circular from the center of the wound out. So if you were to take a swab, let's say you had a pressure ulcer, a circular wound, you would start in the middle and make a spiral, working your way out. Once you've used that whole Q-tip, you throw that one away. If you need to do it again, you start in the middle, do your circular spiral on the way out again. You never want to go back towards the middle with a dirty Q-tip. So if the incision has a drain, you want to clean the incision first and then clean around the drain site. And make sure that nothing's dripping from the drain site into the wound. Okay, there's a ton of different dressing types. I mean, wound care is a whole specialty that nurses train for and get certifications on. So dry dressings, they protect, they absorb. Dry dressings are typically for moisture wounds. They prevent contamination, remove exudate, which is like that gunk buildup, and they promote epithelial movement, so that granulation. Synthetic dressings, there is all kinds of different types. So they are semi-permeable, which means they breathe. They allow O2 to get in there, but have a bacterial barrier. They promote epithelialization. Oftentimes they're changed a little bit less frequently, every few days or as needed. They're a lot more comfortable and they are better for some of those harder areas like joints and things like that. Wet to dry dressings. So these are usually changed every 1 to 2 times a day. Again, there's going to be a specific order saying how often you're going to change the wound dressing. And wet to dry dressings help to remove exudate and debris. So kind of that minor debridement. Maybe there's a little bit of slough and eschar, would use some wet to dry dressing. And it acts as a sponge. So it as it dries, it assists in debridement. When you're doing wet to dry dressing, you want to make sure that the wet part of the gauze or syringe is just in the wound and that you're not laying it over the good healthy tissue, because it'll actually break that down over time. Okay, wound irrigation. So the nurse in this picture is using some saline to help clean out the wound, so it flushes it. And as you're doing that, it's actually going to flush out some of the exudate and debris. And this helps promote wound healing because it allows granulization to occur. Sometimes they'll use a medicated solution. You want to make sure that you're positioning the patient in such a way that you're not going to douse the bed in it. So you want to lay down some chucks or put the foot of the bed down in this case so that the drainage is going away from the patient. Okay, so remember we talked about some of those wounds that have tunnels or fissures in them? Well, what's going to happen over time is it's going to heal, but it's just going to cover up and then it'll eventually open back up. So in order for those tunneling areas to heal, we have to pack the wound so that the wound can actually start to grow in and in and in and in. So it helps to remove the exudate and debris. So there's sterile packing, or that we'll show you in clinic or in lab, or you can use gauze, and it helps to fill that dead space in and promotes granulization from the wound base to prevent premature closure and abscess formation. So usually use like a Q-tip to pack it in there. And make sure that as you're packing it that you're not dragging it on the skin, that it goes straight into the wound, otherwise it's contaminated. And then once it's packed, then you cover it with the dressing. Okay, next we're going to talk about wound vacs, or vacuum assisted therapy. So wound vacs use a mechanical device with a container and tubing and a dressing, and basically this is all set up into the wound. You see the black foam there, and so there's the machine pulls on the wound and pulls out all of the excess fluid that the wound may be producing. So it decreases air pressure in the wound and gently pulls fluid. It helps reduce swelling. A lot of times too they use them with grafts to help the grafts stick, like skin grafts. Helps to remove bacteria. They can actually put different cleansers so that it'll wash the wound and then pull that fluid out, and helps promote a faster healing process. Okay, so heat and cold therapies. So heat is going to vasodilate. It's going to help increase inflammation, but decrease blood viscosity, increase bleeding, helps with muscle tension, increases tissue metabolism, decrease pain. Cold is going to vasoconstrict and decrease inflammation, decrease bleeding, also helps with muscle tension, decreases edema and pain. So heat, you can use moist hot packs, compresses, K-pads, a sitz bath, which is like a special little bath that you sit in. A lot of times they use for vaginal surgeries or post childbirth. Dry heat, like a heating pad or hypothermia blanket, versus cold, we can use moist cold compresses or like a sponge bath. Our dry is going to be ice bags or an ice collar, hypothermia blankets, or the little ice bags that they have on the units. So with heat and cold though, you have to be careful of the rebound phenomenon. So when you put ice on an injury, they always tell you 15 minutes on, 15 minutes off. That's because of this rebound phenomenon. So when you put hot or cold on for greater than about 20 minutes, then you actually have the opposite effect of what you're trying to go for. So the tissues actually get congested and vasoconstrict, it can lead to tissue damage and sensory impairment. So you make sure that you stop this therapy before that happens. So you really want to be careful with the young or the very old, and you don't want to use it in the presence of open or infected wounds. Anybody who's got impaired circulation like PVD, diabetes, anybody with impaired sensation like our spinal cord injuries or stroke patients. So make sure that when you're studying that you know the difference between hot and cold and the different indications. So for heat, muscle spasms, joint stiffness, contractures, and pain. Where cold you want to use in trauma to control bleeding, inflammation, muscle spasms, and pain. So usually, heat for the first 24 hours after trauma is contraindicated, which means we don't want to use it. Any active bleeding or edema or blisters, because it's going to make it worse or make the bleeding or edema worse. Cold is contraindicated on open wounds. You can put it on the areas around the wound, but not directly on the wound. Anybody who's hypersensitive to cold or has asthma or allergies. So usually your facility is going to have a very specific policy about hot or cold, so make sure you follow that and that you're constantly assessing during and after therapy, and that you only apply the heat or the cold for very specific time, 10 to 15 minutes. And make sure that no well-meaning family makes any adjustment to your hot or cold therapy. Okay, so because we're not in class, please feel free to email me any questions you may have. If anything wasn't clear, I'll try to get back to you and straighten it out for you. So make sure you read the textbooks and study the slides for the tests, and I will see you guys in lab soon. Bye.